Thank you for having us today. It's really an honour to be here on behalf of UnitingCare Health. I am a freak and I am a geek, and I'm going to tell you the story how in how many years they will remember us in UnitingCare Health, and we have made a difference. So what we will go through today is how we got here. Can you put your hands up for people who heard the presentation 2 years ago when we came and said how we were going to get here? Okay, a fair few. Okay, good. So for those who didn't, I'll just have a little summary on that as well. Who we are, what we do, and where we're going, really. So to start with, 2 years ago, the group that were here heard us, and we showed this lovely sort of fly-through of what we were going to do. We told you about the risks that we saw, we told you about how we thought we were going to get there, and we told you that we might still be here telling you about it today. Well, this was the fly-through of St Stephen's 2 years ago. This is it today. We made it on time and on budget. Yay! And we still have a hospital running. 5 months later, it's running beautifully. It's a beautiful facility as well as a fully integrated digital hospital, Australia's first. So for those that don't know UnitingCare Health very well, we are part of a larger group of hospitals, and we belong to UnitingCare Queensland as well. We are part of the service group. Now, as part of this digital journey, this might be a familiar face to you. We all get the royal wave. So as part of the digital journey, early on in the piece, Richard Royal, our CEO, went to the States to find out what is it that we needed to get for this project early on, and lessons learned from all the places that had done it there. And if you can see that, the first lesson was really that this project is not an IT project, it's a change management project, and that was completely reinforced during the actual project itself. That you have to develop a very close relationship with the vendor. So that is, for those that you don't know, that's Neil Patterson, that's one of the founding people for Cerner, is now the CEO of Cerner as well. That doctors need to be engaged up front, and for that he recruited me very early on. That you have to have people that have done this before and have done it successfully, and for this we had a very experienced program director, Connie Harmson, who came from the States and done this with Banner Australia, and that you actually have to focus very strongly on the staff and what you do before and get the IT support beforehand. So this is a little bit of a timeline, just to give you an idea of what happened for those that haven't heard it before. The submissions were sought in 2010 from the HHNF to actually see projects that would improve health through digital in areas that were regional and rural. And for that we were successful, and in 2011, lo and behold, Richard got the phone call and the surprise saying, you have got the grant to build the digital hospital. The contract was signed, and July 2012, Connie Harmson was appointed, and shortly after as well, I was appointed to start the project. Now, between there and 2014 is 2 years, and I will tell you a little bit, this is not the shortened version. But really, and then in 2014 in December, I don't know how many of you are familiar with the MRAM scale or HIMSS, but really is that scale that tells you about the clinical adoption, and the digital hospital scale goes from 0 to 7, 0 being nothing, 7 being the highest. But we were the first in Australia to achieve HIMSS level 6. And the reason why this is important is because it has been demonstrated that those hospitals in level 6 and above are the ones where you get real value and real clinical quality and safety outcomes. That photo there is our first patient that went through St Stephen's in our first operating theatre. So what is a digital hospital, and what were the digital components that we had? So if you can see that the base of it is all integrated through Millennium platform, which is Cerner. Then you have the actual iBus connecting everything through. So the important thing is that everything actually comes via the EMR. So any devices go through the EMR. You can see all of them, even from communication, your phones, your workstations, the room links, the meal ordering, the mobile devices, the patient entertainment system, the nurse call system, your building and maintenance system, and it all goes through that one platform. So defining the requirements and what we actually have 29 Cerner Millennium applications. We have 21 devices, and out of that, we actually have to have had interfaces as well with our external providers. So we have currently 2 pathology external providers, and we had to interface with both. And we have a radiology service provider, and we had to interface with that and with food management. And obviously, underpinning all of it, the necessary ICT infrastructure. So the meters and meters of cables, but we have an RHO agreement with Cerner, so they host they host it in their RHO. So what do we actually do, and what does this mean on a day-to-day basis? What is a digital hospital?
We're really excited to have Australia's first fully integrated digital hospital here in the region. It's a marvellous opportunity for the community to be able to come to St Stephen's to have their investigations and their procedures completed rather than having to go to Brisbane.
Cerner are very excited to partner with UnitingCare Health to deliver the first fully digitalised hospital in Australia.
This is a pilot for Australia. We were fortunate to be able to get a government grant to make this a pilot for the country. So all the leaders in healthcare from around Australia, both publicly and privately, are coming to look at this hospital as the future of healthcare.
This has allowed us to join with an elite group across the world of hospitals who've reached this level of digitisation.
Research has shown that these fully digital hospitals significantly improve the clinical outcome for patients, as well as being operationally more efficient.
So we have 29 Cerner applications, we have 20 devices, we have a number of interfaces for lab, for radiology, for our business applications, as well as pharmacy and medical management systems.
Patients are really enjoying our environment here at St Stephen's Hervey Bay. They quite like having the patient entertainment system, the all-in-one computer and TV screen at their fingertips. They can actually order their meals using that on a touch screen, which they seem to be enjoying, having that ability to have control over their meals at a time that suits them.
The nurse or the doctor actually puts in the special dietary needs we need the patient to have, but the patients have their own workstation or computer in the room where they can order from the diet what they would like to eat, and that interfaces right to the kitchen so the kitchen staff see that.
Every bit of equipment is linked into the electronic record. That means there's no handwriting, there's no mistakes being made reading handwriting, there's no mistakes being made about ordering the wrong drugs because it's all fully electronic.
Each patient room has up to 13 data points that are available in the room. A standard room will have 6 of those that we're using at any one time.
You have anywhere, at any computer, within your home, within the hospital, within the theatre environment, within a mobile device, where you can actually look and see most current information related to that patient and their care that's being given. When you have up-to-date information, when you're not fighting to find a paper chart, you have the information that you need, when you need it, where you need it, to be able to provide really terrific patient care.
We get to do real-time documentation, and we do it at the bedside.
The electronic medical record is the one place where I can find all the information related to my patient in real time when it just happened, and actually see what is the best course of action for my patient.
As a surgeon, I would like to provide quality care to my patients. With digital information, the accuracy of information improves, and thereby improving the quality of care we provide to our patients.
Contains everything from the results of their labs, their imaging, the latest nursing observations, the patient education.
Having electronic medical record access 24/7, it allows me to act quickly and keep the patient pain-free and keep them safe throughout their journey in the hospital.
So your medical record's stored in a location called the Cerner Remote Hosting Facility. Your information never leaves Australia. It's actually hosted in Brisbane. It's in a very secure facility. The data's encrypted.
This is our JV8410, one of our oral solid packaging machines. So this produces our unit dose packages And the reason why we produce these is to put a barcode on the outside of a sachet, which encodes the drug contents.
So we've introduced a system at St Stephen's Hervey Bay that allows us to implement a closed-loop medication management.
Barcoded sachets, in combination with the ADCs, which only lets the nurses open up the correct tray with the correct medications. Both of these methods minimise any chance of selection error.
It's a marvellous opportunity for the community to be able to come to St Stephen's to have their investigations and their procedures completed rather than having to go to Brisbane.
The technology is allowing us to put nurses back at the bedside to actually provide care to the patients, which is what you actually come to hospital for.
I think people have been so blown away really by this new hospital and always say how wonderful the care is from the time they come in to the time they go out. I can't fault it.
Here at St Stephen's they have the latest and greatest in clinical devices, and at the end of the day that means the patient gets the best quality care and the safest care we can provide them.
St Stephen's represents the future of healthcare in this country.
That's it, presentation done. But just so that you get an idea, it gives you a much better idea of what we are and what we do. Because anything that we can tell you is really just a little bit. What you actually see is way more impressive. So Tricia's going to tell you about our clinical innovations, how to get there, how we move from paper to the EMR.
Okay, I'm going to start the journey on how we transformed from our paper-based system to our EMR. It was really important for us that we didn't actually just replicate what we did on paper because it wasn't possible, it wouldn't work. And the other challenge we had was we were given an American computer system and we wanted to make sure it fitted us for what we did in Australia, that we weren't trying to change our work practices. So the first thing we did was created these work redesign teams. So there were 8 different teams. Monica will talk more about the doctor teams later. But there were each of the functionality. So there was a team specifically for integrating the devices. There was a SurgiNet team. The CareNet team looked at the ward-based, the nursing procedures. Medication administration was a big project, part of it, and the admin functionality. And at all times through this, each team would talk to other teams and we'd have meetings with groups of teams when we had common problems to solve. So here's how we made up our work redesign teams. They weren't just made up from people at St Stephen's Hospital in Hervey Bay. We actually went to the wider group of UnitingCare Health. You can see we had 62 staff coming from all across UnitingCare Health, and we had 27 doctors. And that's a really interesting thing because these were all VMPs who gave up their time, though I did hear there was a lot of wine on offering to help them come to the meetings. But they gave up their time to come to actually have an input and a say into how we design the medical record. So one of the key reasons they did this was our work redesign teams were working on the 80-20 rule. 80% of the EMR and the design decisions we made had to fit in with every site in UnitingCare Health, whether it's our smallest hospital in Hervey Bay, St Stephen's, or our larger hospitals in Brisbane, the Wesley and St Andrews. We also, the design was very clinician focused and it was also very much based on evidence-based practice and the best practices. We always had to look at our standards, national standards, ISO, hospital policies and procedures, licensing, the list goes on. And at the very, very centre was always patient care and patient outcomes. We were doing the best each and every time for our patients. So some of the things we'd come up, and I apologise, some of these screenshots probably don't look too good, but some of the stuff we come up with was clinical pathways. So this wasn't in the Cerner build. We were able to create these nursing, what would be a clinical pathway or a care plan in the paper world. They're very goal focused and they focus on outcomes and interventions. And one of the biggest benefits we see for this is we can actually measure our patient journey. So we have 20 surgical plans that match the surgical power plans the doctors wrote, and we have 6 of our high-risk patient safety ones, i.e. pressure injury, falls risk, skin integrity that we put into place. Blood product administration was another very big challenge for us. So as a project team, we were told by our Cerner associates that nobody had ever put a fully integrated blood administration system in, and we were like, we will be the first. Famous last words, it was not as easily said as done, but we have actually managed to achieve a fully integrated ordering and administration. So it actually interfaces with our provider, radiology provider, and with the blood bank. And it's a full closed loop medication blood administration, which is fantastic. Another one we had to do was deteriorating patient to meet standard. So Cerner already did have some colour coding available, which worked very well. They had between the flags, but our organisation had decided to go with QADS, which is the Queensland Adult Deteriorating Detection System. So we had to rebuild it from scratch, which was an exciting opportunity for us. So the way it works, it does actually add up scores for the patient, and it gives the clinicians alerts as the patient's condition deteriorates as to what exactly they should do. VTE risk screening was another one we had to design from scratch, and it interfaces with our doctors as well. So nurses do a screen on admission, the doctors do their documentation, and it also suggests power plans based on for the doctors to put into place. Pain management was a big one. This was very multidisciplinary between the anaesthetist team and the medication management team, and of course the nursing staff. And we had to take what was a paper system, including the devices, and put it into the electronic system. So we've managed to do that with power plans and integrated doc sets. So it's actually one way that it's ordered the medication management from the doctor, but also the nursing documentation. It complies with our hospital policy. Warfarin management was a great one to tackle. As you all know, warfarin management takes lots of monitoring, can be very difficult to manage. And Cerner gave us two options for warfarin management in their system, and we didn't like either of them. So we were very luckily offered the opportunity to come up with our own plan. So we had some very smart people on the team that were great innovative thinkers, and they come up with some warfarin management plans and some M pages. So we've actually created the warfarin management plans, and we're actually working with Cerner and some other sites in Australia to create the mobile pages to go with the warfarin management. So that's going to be fantastic, and lots of people are waiting to see how this turns out. Living values. So we were able to customise our electronic medical record to meet the needs of the organisation. We have living values, which is due to principles in UnitingCare Health. And it was really important that we not only put it into the MR, but also into the practices of how we dealt with the patients. Last but not least comes clinical handover. Of course, everyone else goes with SBAR, which would be nice and easy, but the organisation had decided to go with a shared handover. So we created our own pages to meet how we need. And each and every time we hand over, people see the same shared pages, which pulls the information from the EMR. Another big one, a big challenge, achieving closed-loop medication management. Now, this could be an hour talk all by itself, so we're going to glaze over a lot of it. And not really talk to a lot of the challenges that our Vicky Ibrahim, who's our Director of Pharmacy, actually was challenged by. So what is closed-loop medication? Closed-loop medication means that it's ordered on the computer, there's clinical support decision-making at the time of ordering it, that it's dispensed in a single unit dose packaging, which sounds easy to say, but there was nobody in Australia to provide unit dose packaging, and St Stephen's Hospital in Hervey Bay actually had to put in equipment to do their own unit dose packaging. Pharmacy have to verify the order. It has to go to an automatic dispensing cabinet. We need verification at the bedside. And we also need medication reconciliation on discharge and interfacing. So that all sounds good, but what does it really mean? Basically, it means our doctors can put in our order, they can do it remotely via our Citrix server, or they can do it on any computer in the hospital. The pharmacy then verify the order, and they will actually tell the nursing staff exactly where they will find it and which ADC machine, or if it's a special patient supply medication which has been barcoded by the pharmacy. That order will actually interface with the ADC in the room, and there's also another program the nurses can use to line up their medications for their 8 a.m. medication round, so we don't get a big backlog at the ADC. The ADC will only dispense that one medication at a time in one dose. We then have patient barcode scanning and medication barcode scanning to check the 7 rights before they safely administer the medication. Now, the other huge benefit we have, we've worked really hard on, is our interface system. So our EMR is our one source of truth. We don't have double entry like into the medication record and then to another program like we use Merlin. So it interfaces through our middleware, goes to our ADC, it goes to our Merlin, our software one. It also interfaces with SAP for our billing. It interfaces with Simium for our wholesalers for restocking. And it also, we have paperless PBS claiming, which comes from that interface. And here's our pharmacy's favourite little barcode joke. Right. Now, behind the scenes, the infrastructure and security. I'll be the first one to put my hands up and tell you I'm definitely a nursing background and not an IT person, so no complicated questions on this one, please. Basically, right back at the start of the project, we realised that having an electronic medical record brought a higher demand for being reliable. It needed to be high performance. We needed our security in place. It really needed to be mobile and wireless for it to work for our clinical staff. They all needed integrating, and very importantly, we needed business continuity planning solutions. We've hinted at it before, but it's remotely hosted. So at times we do go down. For example, was only on the weekend, we had a huge storm in Brisbane and it took the system down. So up in Hervey Bay, they need to know what they're going to do in that event. So basically the infrastructure. We use Citrix as a desktop, and the remote server is actually hosted down in Brisbane. Our Cerner also sits on a remotely hosted system, which is high level. Communications, they've got 2 exchanges that go through. In the local area network, there's 10 communication rooms, and they actually have 10 gigabit redundant fibre, and it's all wireless. Another big part of the program, what we had to look at was actually looking at our current one and remedying the gaps that we had. So we had to look at our remote hosting solution and would it be good enough. Outsourcing our operations and our help desk support, there's been a huge change in our requirements for them going to a fully integrated EMR from our previous solutions. Our technologies and increasing our WAN bandwidth. And our Citrix remediation activities, which I often say Citrix remuneration activities because someone's going to pay for that one. And here's some quick facts for the nerds in the room. We have 160 wireless access points in St Stephen's Hervey Bay, 9 service set identifiers. Each patient room contains 13 data points and there's 96 rooms in the hospital. Each room has redundant fibre optic links, 2 on-site data centres, 10 different communication rooms, and over 1,500 wired devices and 500 wireless devices on the system. So integrating the devices to the EMR. Okay, earlier Monica showed you this picture of what we identified, how we wanted it to work way back in 2012. Now, anyone who's been on a big project like this would know we often start with a great picture like this, and one by one we slowly cut off the nice to haves but the not so goods. So we're quite happy to say we have actually all of these solutions in place at St Stephen's. And one of the other fantastic solutions is using the iBus software and our own middleware. We only use the EMR to integrate to everyone using HL7 messaging. So here's what our patients' rooms look like. In Hervey Bay, the patient entertainment system you can see there. And the patient entertainment system is the patient's diet system and also patient's TV, etc. We do have the capability for the electronic medical record to display on the patient entertainment system, but that was something the nursing staff at Hervey Bay decided they definitely didn't want to do, so we don't use it for that. We do have the in-room workstations in our surgical ward, and the wows. And theatre didn't miss out on their devices as well. Theatre have all integrated devices with their Striker. We have PACS gear for clinical imaging capture, GE monitoring, and the anaesthetic machines, which interface across to the EMR. Now here's one of the favourite devices up St Stephen's Hervey Bay, and it's the Vocera badge. So the Vocera badge doesn't interface to the electronic medical record as such, but it is a wireless communication device. Is anybody else familiar with the Vocera badges? Yeah, this is the nurses, probably one of the biggest wins we've had with the nursing staff. It's voice activated, hands-free. And it's actually linked to the nurse call system. So when the patient buzzes, it will buzz on the nurse's nurse call and doesn't buzz in the overhead. So we actually have a really nice quiet. We've also got Alert Link, which interface it with our GE monitors. So if a patient's cardiac rhythm changes or their observations become critical, it will actually alert to the nurse onto her badge as well. Now, we talked about the patient entertainment system. This is the nurse's entertainment system, our workstation on wheels. In the United States, they call them a computer on wheels or a cow. We decided that was not very PC. But it is actually more than just a computer. So this is the option we went for. It does have a computer and a battery pack in the bottom, so it lasts 2 shifts before it's got to be plugged in. You can see in the middle picture, the side of it actually has locked drawers. So the nursing staff can actually have 6 different locked drawers, so they can actually get out their patient medications, lock them in a drawer and do a medication round rather than always going backwards and forwards. That's been a big win. Each wow has its own barcode scanner. And in the bottom left-hand is our Improvator, our single sign-on. This has been another huge win with our clinicians. Using the Citrix session, we have tap-on, tap-off security. So with the ID badges, they can tap on and tap off when they leave a patient room. There's no manually entering their information. And our ADC. So the biggest difference with our ADC is it's not just a glorified vending machine. The medication order in the chart will actually interface with the ADC. So when the nurse comes to the ADC, it will actually be the medication and the dose ordered for that patient. So it does keep up with the closed loop medication administration. And here's all of our mobile devices in one nice picture that all integrate with our electronic medical record. So how does an integrated system really work? So here's an example of an ECG order placed in the chart, which can be placed by the physicians remotely if they're on the ward, or it can be put in by a nurse if they're worried about a patient. That order actually wirelessly interfaces across to the Mortara cart, the ECG machine, so it pulls in the patient's identifying information. The nurse takes the ECG on the machine and it wirelessly transmits back to the electronic medical record. It then displays in the chart as completed. Now the doctor, if they want to see this ECG, all they have to do is click on the completed and it will pull up an ECG in their chart. Even better than that, another big win we've had is we can now have employed heart care partners who are hosted down in Brisbane, and they actually interpret all of our ECGs. So in the past, in a facility at St Stephen's where it was rural and remote, we might take an ECG, but we had a huge trouble trying to get it to a doctor to interpret. So many of us have seen how good a faxed ECG scan actually looks. So now we can actually call heart care partners and they can actually use PowerChart ECG to interpret and give us advice regarding the ECG. Another big win's been capturing clinical images. So this can be done on the ward, or it can also be done in theatre with our PACS gear, interfacing with our Striker, all of our equipment. So we have the Ricoh camera, which is actually very interesting because our younger nursing staff at St Stephen's have actually looked at the Ricoh camera, and many of them have never had a camera. They had only had iPhones and iPads. So that was quite challenging for them, but us Gen Xers were very excited about this. So basically it uses barcode technology to gather the patient's information. You take a picture of the wound and it comes through to the electronic medical record, and you actually pull up an image in the electronic medical record. So this has been great for capturing things like our pressure injuries and the management of our wounds. We're not getting so many pictures on, or any pictures on iPhones by anyone. So what integrations do we have? Our pathology and lab orders all interface. Our electronic meal ordering system we've discussed, ADC. We have RoomLink, which is the machine sitting outside a patient's room that alerts to something like if they're in contact precautions, there are falls risk. We have real-time tracking, which is all our equipment, but also we can track our patients. And all of our vitals devices interface to our electronic medical record. We also have lots of the other integrations which benefit our workflow but don't go into the EMR, such as our patient entertainment system, our nurse call system, our managing of all our supplies, interfacing with SAP is the product we use, and our Vocera badge. And like I said, we use our middleware HL7 messaging for that.
So how was our doctor engagement and adoption strategy? Is that my mic going back on? Our doctor engagement strategy was based on the pillar of always having tailored VMP support during each particular stage, but always partnering with them. So as Tricia said, VMPs are visiting medical practitioners. None of them are staff, they're all visiting, they all have their own businesses to run. So it was very important for us, if we wanted to have doctor engagement, to bring them on very early on in the piece. And as we mentioned before, for our doctors to come from across the whole group as well, so that if we ever move this out, they actually know what we're talking about. So during our pre-implementation phase, we did our advice for those early champions and clinical champions that wanted to be involved, but not the ones that usually are involved in the IT stuff, the ones that go into the corner with the geeks. We wanted people who wanted to be part of the change management process as well. So we asked for expression of interest across and sent thousands of letters across all of our facilities. And from that, we got interest from very different people. Yes, we got the interest from the people who like to play with toys. And we also got people that were interested in the actual change process, which was very interesting. During that pre-implementation phase, and I'll go into it as well, we did the one-on-one meetings with them as well. And that support and our partnership with our doctors continues through the implementation and through the go-live. So during our early phases as well, what we actually wanted to do is get them involved also in how to design their training. So when we mean doctor engagement, we don't mean go and ask after you've done it. We mean truly ask them what they actually think, what they actually want, and tailor it to them. So the learning plans, the learning packages, the learning modules, they were all tested by a couple and tailored to what they thought a surgeon would like, a physician would like. So these are our doctor teams. So we divided our doctor teams early into the physicians and the surgeons. So they as well elected their own chair. I facilitated the meetings, but I was not the chair. The chair for the physician group was an intensivist from the Wesley Hospital, a big, large hospital. The chair for our surgical group was a urologist from the Sunshine Coast private hospital. Now, the anaesthetists were interesting because they started in the surgical group, but very early on, they had very different interests to the surgeons. So we actually split them on very early on, and they went to play with toys, but the surgeons just wanted to actually do what they wanted to do. So the critical part of the doctor teams was that we went with them with what we actually wanted as well. So we said, look, we actually want to get out the actual power plans, or that's a fancy word for, clinical plans or whatever you want to call them. But what this would be creating would be a standard of care that would be in the EMR and is now into the EMR. So when they got together, we actually did a lot of work. So we identified the top DRGs for St Stephen's Hospital. So we went, these are the most common ones, but we also went for the higher risk ones. So that's when we actually went in, we scanned hundreds of the actual charts and went to see what the actual practice was. And our teams as well went and found all the evidence behind what was recommended as best practice and got all that together. So when the doctors got together for 3-hour meetings for 10 weeks every night, it was actually using their time efficiently. And as Tricia said, it wasn't easy to keep them interested for 10 weeks, for 3 hours from 6 o'clock till 9 o'clock. But they actually were consumed by us, and they knew that they were actually creating something that was relevant, clinical, and they will be using later. So they were we developed 43 clinical plans. It was an interesting journey. We had to, as you say, Queensland's a large area, so we actually couldn't have them all in a room. So this was all done via video conference as well. And I made sure that I was at one side at different times so I could facilitate, and we had a facilitator on each one as well. We had live meeting to look at the screen. Yes, we had lots of bottles of wine, but you've got to keep them entertained. And after that, we actually developed as well a plan to move forward. So learning engagement plan as well. Each one of our doctors in St Stephen's signed a learning agreement or a learning plan, which they told us what they thought they needed and signed as well to say, this is what I need, after a discussion one-on-one, which what I thought they would need. So the actual measured number of total doctor hours in our first phase of pre-implementation was 871. I can tell you there was way more hours than that doctors were working on and trying to find out what they would bring to the table. It was really important that they understood what they were designing. And I always use the analogy of a car. If you're going to buy a car, you actually get the brochure, you can Google it, you can look at it, but until you actually get in that car and drive it, you don't know what you're buying. So it was very important that our doctors actually saw what they were getting. There's no facility like this in Australia, so we actually took them to a facility. This is Memorial Herman, and all doctors, we love our toys, so we went to the helipad to find out what they were doing for transfers. But we took a surgeon, a physician, and an anaesthetist, and myself as facilitator, to actually go there and talk to their peers, to actually see it, to find out what was it all, warts and all, what was good about it, what wasn't good, what they needed to look out for. Most importantly, and that was the surgeon who asked the question, would you go back to paper? No. None of the sites said they would go back to paper, and they were with their own peers as well. Very important as well to actually get them in the testing phase. So we actually had, again, surgeon, physician, anaesthetist, and all of us going through testing scripts. And the testing scripts had been actually gone to a core group of doctors as well to make sure that the testing script was relevant to the rest. So everything was really well calculated, and it was systematically done with input from our doctors. Now, the pre-implementation as well, we said to them, look, you'll invest a fair bit of time now, but the moment that you go live, you'll have less time. So what that meant, we put in a favourites fair, so we loaded all their templates, all their pre-completed notes. We had hours of going to so their learning also included setting up their favourites, showing them what was their medication routine, and we'd analyse that so we knew what each doctor wanted. So training was one-on-one. I did training of all the doctors, and as well we identified super users. For example, anaesthetics, we already had an anaesthetist who was so engaged that he then took some of the anaesthetists through the training. Again, one-on-one, identify what they need and then make them part of the plan. Important as well, they all wanted to participate in the mock go lives, and that included the one, which is just the devices, but also the mock go live 2, which is our patient journey through it, and be part of the debrief and be part of the training. So we went live. We went live October 13, 2014. And very important that for us that the red shirts are the doctor support team, so that could be easily identified. They could actually go and they would actually say, go and get me a red shirt, because they knew exactly what they needed to get. That one-on-one support, being there for the first operating theatre, for the first rounding, and being there from 6 o'clock in the morning when they're going to do the first round, all the way till 10 o'clock at night where the last physician is finishing rounds, and making sure that the next day is ready. That engagement did not stop at Go Live. That engagement continues post-implementation, because they are truly engaged by now. They understand. You should hear them talking about power plans, M pages, everything that they know about changes, but you want them to be involved. And the involvement as well, when we put in the EMR, is that remember we opened a new facility, so there's lots of ops bits as well that needed to be, cleaned out, and so making sure that they're engaged in the actual opening of the facility, which separates the EMR, and you don't say, oh, that's just the medical record. It's not. It's actually a workflow issue. It's an operational issue. Making sure that your super users are developed as well and they continue the ongoing performance support with doctor engagement, and they know who to go to and they know how to make a change, and we have a strict governance process around it. Don't intend you to read, but post-implementation, this is what data can do for you. So I can log in as CMIO and I can look at how many of those clinical plans, of the 43 clinical plans, how many are being used, which one's not being used, why it's being used, who's using it the most. I can do this for actual one particular clinician, I can do this for a group. So I can actually see day to day, if I wanted to, exactly real data in real time. But it's all good to have all this, but how do we measure what we're doing? How do we know that what we're doing is actually meaningful and will provide some real clinical impact? We have a very robust benefits realisation framework from the start as well. And what we did with our leadership group from UnitingCare Health early in the piece, so this was February 2013, so have a big workshop on what do we want to see coming out of this, our big benefits. So these were the benefits identified by UnitingCare Health's leadership group from across the whole of the hospitals that we said this is what we want to see and measure. So each one of these as well has been developed into a whole benefit that we want to analyse, and for that, I don't know if you know, but we do have the Wesley and St Andrews Research Institute within UnitingCare Health, and they were engaged very early on to develop the whole research framework and rigour around it as well. They developed the QM study, which is the clinical outcome study as well, and that is part of the whole program as well. So, for example, simple things, point of care device. So is that for us, the decision, we wanted to go evidence-based, there was nothing around it. So what we did is we actually put some fixed workstations in some of the areas, and we actually have the mobile devices, and we're doing a comparison study where we'll analyse with Australian data what it is and propose and find out what it is that we need to go into the future as well. Yes, but how do we pay for it, and is it really worth the money? Very important piece of the benefits study as well was to actually engage, and PricewaterhouseCoopers has been engaged in analysing what the actual financial cost and the financial return was, direct and indirect costs. Now the initial business case estimate is coming at the end of this month, and they will give us a draft of what they think this is, and it will be published, and by June 2016 we actually will have 12 months of data, so we can actually demonstrate that. So what does this mean for Australia from the benefits is that we will be able to provide evidence in Australian territory of what the benefits are from our clinical quality and safety, from our financial perspective, from a workflow perspective. And this actually will be able to, from other eyes, from the funding eyes as well, be able to see how this proves that you do have good return on investment. Okay, so what have we learned? Yeah, that could be another hour of talking, but really I'll summarise it. And where are we heading with all this information? So what have we learned? We've learnt really that strong leadership, strong engagement, and I say that because we really had an amazing leader in Richard, and it's actually, and the determination to succeed from all the clinicians was the first and foremost most significant thing of our project. That a risk management approach, they actually identify those risks and do a whole plan to mitigate it. I was reading the risks that we presented last time, and they were all ticked, they were all managed, they were all mitigated. And you have a project this size, your governance framework needs to be robust, and as well tap into current governance structures so it's not separate from what you currently use for your governance. This is a key, that your vendor you can, using our leadership structure, we can actually push them to say, I think you heard Trish say how many times they came back and said that hasn't been done before. Let's do it this time. So I think at some stage they said, to me, and for a doctor thing, that hasn't been done in Australia. And I said, how many times have you told me that? And how many times have we designed it now? So it's really important to have a very strong relationship with your vendor as well. Go to other sites, find out what's worked for them, what hasn't. For us, we didn't have another site like this, so we had to go overseas, but you guys now do. You have us. So make sure that you reach to those who know. We have a whole team now of experts in Australia and our team that know about it from all ranges, pharmacy, nursing, medical, finance, everything. The other key learning was as well, and you saw that with all the cabling, is that the work required on the actual infrastructure to run this is enormous. And that when we had a big facility, we actually ran the data centres and hosted it at the Wesley. I don't know if you're familiar with the Wesley, very, old buildings in there as well. So the infrastructure to get from there to a regional hospital that runs on a digital capability was actually huge and required a huge investment. And we're still working some of the remediation program for the rest of UnitingCare Health facilities. We learned that when doctors are engaged and truly engaged, not just consulted, but truly engaged from the start, it's a real positive and rewarding experience, and they continue to be engaged in it. That we really need to have a very close connection between, if you're doing a fix, I think week 2 or week 3, they did a fix on the building management or the air conditioning or something, and it had a huge impact on the rest. So you really need to know where your impact's in and have a good governance structure around it. Your super users are gems because they're out there not only teaching people, but actually doing more and finding out bugs and finding out, what was the word for bugs? It wasn't bugs, it was something else, the positive.
Features.
That's right, the features. And that in the end, some staff will be actually fundamentally challenged with this change and they might leave, but that's okay. Because those who stay actually embrace it and move on quickly as anything. This was week 1, getting rid of all our pathology ordering system. It was tough getting rid of them. You should have seen some of the people trying to run after them. So what's next? You saw that little bit of slide on where I can log in and find out exactly what's happening with our data. That's the same for the operating theatre manager login. You can go in and find exactly which is the surgeon who has more delays, how many theatre cancellations per day, what's your turnover, real time, real data that you can't sit at a table and say that's rubbish data, because it's not. It comes from the actual EMR. So managing it and maximising and where to go next is our challenge now, and how to manage it quickly as well. Our next goal is to achieve HIMSS level 7, so that highest level of the MRAM scale as well. But for that you need 12 months of data and using your data to improve your outcomes. So for that we have to demonstrate the 12 months of data, so we will be achieving that. The benefits realisation study will give us a lot to see how we expand this to the rest of our facilities and how we expand it. I can tell you at the last medical advisory committee, they said, if you're going to do it, don't do application by application, go big bang. Much better for everyone. That's their perspective. And what we can do with this. So the development of population health in the Hervey Bay region. So we're the only private, actually there's another smaller one, but we're the largest private operator there. We literally have the public hospital across the road, and we have a very engaged community of specialists and GPs. What we can do for the health of Hervey Bay is incredible. It's a population that is growing very quickly, very high level of chronic disease, which the management actually the challenge will be, how do we actually improve health of everyone in the population, and how do we use our data to do it? So what I actually think is that this is not the future of healthcare. This is the present. It's here, it's now. And if you haven't thought about digital health, if you haven't thought how you can use it, you're running in the past. This is not the future, this is today. The future is actually personalised healthcare delivered by big data, is actually population health. Digital hospitals is the present. Thank you.